starting. All attendees are in listen-only mode.
Good evening. This is Dr. McSherry, and faculty tonight guest is Dr. Laurel Walton. Tonight's webinar is on August 5th, 2014. We have two candidates scheduled for tonight, Dr. Hung for Case of the Day, and then Caseless Mock Orals with Dr. Williams. So what we're going to do is start off with the Caseless Mock Oral with Dr. Williams first, and you make sure Dr. Williams is here. And I don't see Dr. Williams here just of yet, so let's see if Dr. Hung is here. And if we don't have either one of the people here, then we can just take some volunteers. And that person's not here either. So let's see here. I know somebody did volunteer for tonight. And let me go ahead and see who the volunteer was going to be. Go down. And Dr. Williams is not here. Poor Dr. Williams. Unfortunate. Okay, we did have a new scheduled person for tonight. So let me just see, go back to my email. Inbox. And Dr. Suhag. Let me see. Nope, no, not here. Okay, I need a volunteer tonight. Does anybody want to volunteer to do their case list or case of the day? Please let me know. Send me a text message to my cell phone, 701-640-9562. I know Jolak. Jolak, I hope you're here. I can call on you tonight. Dr. Jolak, do you want a mock oral tonight?
What?
You want a, yeah, you want a mock oral?
Yeah, sure. But be nice.
Be nice. Oh, well, you don't ask me to be nice. It's gonna be Dr. You know, the other doctor.
Look at this. So I have no idea what you guys do. So what you do? You go after on my case list?
Yeah,
or?
case list.
Yeah, bring it on.
Okay, bring it on. Okay, Laurel, you hear what he said? Bring it on. Okay, so what would you like to do, Dr. Jolak?
OB.
OB, that's fine. That's one of Dr. Walton's favorite topics, by the way.
Mm-hmm.
So. Okay, Laurel. Laurel, are you okay moving the screen around yourself?
I think so.
Okay, let me just make it a little bit smaller here so we can see it in the screen. There we go. There we go. Okay, let me just take it and give it over to you. And I'll give the keyboard and mouse to Laurel. Okay, Laurel, see if you can move it around. There you go. You're good to go.
Okay. Let's see. Okay. I'll try not to be hard on you because you're just starting. Okay. But I can get picky. Okay. But I'll be nice tonight. I had a rough day. Okay.
I'll be nice to you too.
Okay. I want you to define for me oligohydramnios.
It's an amniotic fluid, total of amniotic fluid less than 5 centimeters on an ultrasound.
Okay. If you wanted to induce somebody, like you did on your first case for IUGR, I want you to tell me, is that the definition that we're using today?
Intrauterine growth restriction?
If you're going to induce this patient, I'm assuming you had an IUGR and an oligohydramnios. Are you using that definition you just gave me to induce this lady?
Yes.
Is that the correct definition?
For the IUG, yes, it is.
Okay, I will tell you that is used, but the definition right now that they're using higher than 5 is actually a pocket 2 centimeters or less is what they're using. I just read it 2 days ago. I'm not meaning that you have to use that, but I would tell them there are 2 things that we use for oligo, either a vertical pocket less than 2 centimeters or you can use your 5, okay? Because the one that they're thinking is more reliable is the vertical pocket less than 2 centimeters without the cord in it, okay? All right, so what's the definition of IUGR? How do you know baby's IUGR? better yet, give me, let's take it this way. Give me a differential of what causes IUGR.
Differential for
Yeah, what causes IUGR?
one is maternal condition, which can be because of diabetes or renal problem or hypertension, pregnancy-related hypertension, chronic hypertension, gestational hypertension, preeclampsia. Also can be because of antiphospholipid antibody. So that's because of maternal medical condition. It can be because of substance abuse, like tobacco and alcohol or cocaine. Also can be because of multi-gestation, can be cause IUGR because of growth restriction. Also can be because of placental abnormality or umbilical cord abnormalities can cause IUGR.
What kind of placental abnormalities are you talking about that would cause IUGR?
Placental abnormality, it can cause because of abruption, if there's infarction, chronic abruption, can be if there's hemangiomas, yeah.
How about a placenta previa, creta, preaccreta, increta?
No, not really, because like those are like the location of the placenta is causing to be located with where it is through the uterus, but it's I don't think it can cause it. Can be, but it's not like definite.
Well, a placenta previa does because you have limited space and a smaller placenta, so we have decreased perfusion.
Okay.
So yes, it can, but I just okay. Do IUGR babies? Is there a difference between? If I asked you to give me the difference between symmetrical and asymmetrical IUGR, what would you tell me?
If symmetrical, if the whole baby is small as the head and the body. Asymmetrical, if it is difference between the growth of the head and the body.
Can you give me an example of both?
For both IUGR, I would say that if a patient have like hypertensive or preeclampsia, it can cause mostly complete like a IUGR, a symmetrical IUGR. With the one that asymmetrical IUGR, I think it would be more into if it's sudden onset of problem, so it will be more placental problem possibly.
Okay, or you could have said something to the effect on this. If you guys get lost on it, you can always say, well, so, like you did, symmetrical involves the entire body. It would be something that occurs at the beginning of the pregnancy, such as a genetic problem, whereas asymmetrical would be something that occurred in the middle of the pregnancy, for instance, like you said, placenta, okay, or mom's not eating well, or mom becomes preeclamptic. Okay, because it spares the head. Okay, what's a Category 3 tracing?
Category 3 tracing, which is when you have repetitive decel or repetitive or bradycardia, or one of them is sinus tracing.
And what else has to be with that? With all of those things you said to me.
With decreased variability.
They have no variability, absolutely no variability.
Yeah.
So it's a flat line, just like if you're on an EKG on an adult and they die on you, it's flat.
Yes.
Category 3 tracing is flat, no variability. That is a definition. No variability, sinusoidal, bradycardia, and variable decelerations or late decelerations. Okay.
Yes.
Okay. Now, you did an operative vaginal delivery on case number 2. Versus you did a C-section on case number One, how do you make the difference between when you want to do a C-section and when you want to just do an operative vaginal delivery?
One, if the baby is almost like a deliver, which is like +2, 3, so it's easy to, and the tracing is tolerable, and the mom is pushing, and will be easier to just deliver the baby. Versus if it's like far from delivery and tracing is worse.
Okay, so she hasn't got to the point of pushing, and you get a Category 3 tracing. Now, what do you do if you get a Category 3 tracing, and you don't have anesthesia right there to assist you to do this C-section? What are you going to do?
First, we do the corrective measurement, which is oxygenation and repositioning, and checking, and do a pelvic exam to check for the dilation and repositioning, as I said, and hydration, and if there's to check if there's a core prolapse, so which can prevent it by pushing, or if there's something that we can help until we can get into anesthesia. But then if it's unpreventable and baby the tracing is getting worsening, then I'm not comfortable. I never did it before, but then maybe we can do a C-section under local anesthesia.
They do ask that question, so everyone should know how to do a C-section under local anesthesia. I've never had to do one either, but I think I could describe it to you. So just make sure you know how to do that. Now, back to these IUGRs. What's the complication of an IUGR baby anyway?
Complication for delivery or for complication? It can be one feeding problem or growth problem, or stay in the hospital in the NICU in a prolonged time, or it can be fetal death.
Okay. Do IUGR babies deliver early?
Not that I know of.
Well, you delivered one early.
Yeah, but maybe because sometimes because if it's the placenta, it's caused because of the placenta is like.
Well, you told me that pregestational in your definition, that you said pregestational diabetics have IUGR babies, and I agree with that. They can be, most of them are small, and they do deliver early.
Okay.
So do gestational diabetics. So complications would be if you have an IUGR baby or a baby that delivers early, tell me the complications that baby would have.
Meconium aspiration, respiratory respiratory difficulty, not difficulty with their holding sugar with nutrition, and holding on to their.
What happens to their heads?
If this head is smaller?
No, intracranial hemorrhage, I want you to say.
Yeah.
Now, remember, if you got a baby that delivers early, you should be able to say 5 things. Always with me, your differential has to have 5. So if I ask you a question with me, everything has to have 5 answers. Okay? So intracranial respiratory problem, we know that. Polycythemia, we know that. What happens? They get intracranial hemorrhage. What happens to their gut?
To their gut?
Yeah. Is their gut developed? No.
No.
So they get membranous colitis, not membranous colitis, but they get, I can't even think of my term tonight. But they get GI problems. They have GI problems. They have, what happens to their calcemia? What happens to glucose?
Will be low. Will be low. Hypocalcemia and hypoglycemia.
Well, usually they're hyperglycemic, hypocalcemic. So it's hyper and hypo, okay? Hyperglycemia, hypocalcemia, polycythemia, intracranial hemorrhage, respiratory problems, polycythemia. Yeah, think of those things. That's what you're going to get asked. Now, you did an operative vaginal delivery. What kind of operative vaginal delivery do you like to do?
I prefer to do a vacuum.
Okay, tell me how you do a vacuum on a patient. Tell me what settings you put your machine on. Tell me everything about where you place it. I want to know how you did it.
Okay, Oh, I use a hand operating vacuum, which is soft cup. We can say kiwi or no?
I think you can, but again, if you say a name, they're gonna, and if the person who's sitting in front of you knows it, they're gonna ask you everything about it. So
Okay.
I think you can say it, but if you say it, make sure you're gonna know every detail about it. If you say a soft cup, you kind of leave yourself open to be able to say a little bit more about, they aren't going to know what the pressure on your gauge is.
Yeah.
I might, but they may not.
Yeah. Yeah. So I usually use the soft cup vacuum hand operated. So I do in that delivery the head was around like +2. So I did a public exam and I looked for and I placed the vacuum all the way under the occiput posterior, and I placed the pressure while the patient was pushing. I pulled downward all the way until to pass the pubis bone and rotate, not rotate, with the contraction, and I deliver vaginally.
Okay. Everybody's going to have to answer this question at some point for somebody. You never want to say pull. You never pull.
Okay.
A gradual downward traction as my patient pushes, I would deliver the head. Downward, gradual, okay, pressure. Never pulling, never grasping, never, And now, I want you to specifically tell me where on the head you put that. Now, if you're at a +2 station, is that a low outlet or is that mid outlet? What kind of delivery is that at a +2, +3?
That's I need to read on those. I don't know.
Okay, you know what you need to read on that. Hey, where do you put that cup on that head? I'm not quite sure where you put that cup.
I use the kiwi. Let's go with the kiwi. I use the kiwi, and I place it on the posterior occiput, and I.
Well, where's your fontanelles?
The fontanelle, I place it behind the posterior fontanelle.
No, you don't.
Well, wait. I place it. Wait, the fontanelle is the bones, right? Not the thing. So I place it all the way posterior on the head.
Okay.
And that will give me more rotation to flex the neck while I'm downward gradually placing traction. So it helps with the traction of the head while I'm
Okay, everybody needs to practice this. 2 centimeters anterior to the posterior fontanelle. You place that soft cup. Whether you're using a kiwi, I don't care what you're using, but place it 2 centimeters anterior to the posterior fontanelle. Okay? You only put it on when she's not pushing. If you're putting it on for the first time, you make sure that you don't have any of the vaginal canal, mom touching it or caught in it. And then what do you put your pressure on to give this downward gradual pressure or delivery, a downward soft traction?
I place it less than 600 millimeter mercury.
Is that in the green or the red zone?
It's on the green zone.
Okay. Yeah. All right. Okay. Very nice. Okay. We'll get you to get there. Okay. What do you induce with? What's induction mean?
Pardon me? What's the induction mean?
What's induction mean?
Okay. Usually when I'm inducing a patient, and it depends on how favorable her cervix is. So if her cervix is favorable, which is if it's more than 1 to 2 centimeters, her Bishop score more like 5. I'm killing myself now.
ABOG would say 8. ABOG will tell you 8 is favorable, but I usually hedge and I'll say 7 to 8. But ABOG is very set in their way. 8 is a good induction. Okay, so you got to have a Bishop score. So you said Bishop score. So what's a Bishop score?
Cervical dilation, effacement, station, the consistency of the cervix, and the position of the cervix.
Okay. What's your maximum score?
11 or 12?
You sure?
No, not. Max Bishop, if it's 2, 5. No, it should be like more. I'm not sure.
I'll let you weigh on that a minute. Okay. Tell me about what's the protocol for a group beta streptococcus positive patient? When do you check for it, and what do you give your patient in case number 6?
I check for group B streptococcus around at 35-week visit. The reason is because of the result of the culture is valid for 6 weeks. And by the time that she might be going to labor, I'll have the result. If the patient is group B positive and have no allergies to penicillin, I usually use penicillin, 5 million units initially, and then 2.5 million units every 4 hours until delivery in active labor.
Well, what if you don't know if she's in active labor?
Then
What's active labor?
Then it's to look into if it's primate and she is 1 centimeter and she's not contracting, I will wait till go into 4 centimeter. If it's a multi, then I will start earlier with the antibiotic.
Yeah, and some of us will use different definition than that. So sometimes you may have to state what your definition is, because some will say when my patient is in labor, with definition of labor is changes from her initial exam 2 centimeters. Some will use active labor is by the new definition of active labor, whether we're latent or active, is 6 centimeters.
Yeah, I know.
So again, definitions are you really have to know them, okay? Really have to know them. Okay, what if your patient is allergic to penicillin and you did not do any cultures?
If she's, then we'll check what kind of allergy she has to penicillin.
She has an anaphylactic reaction.
Anaphylactic reaction, okay. Then, first of all, we'll check if what's her risk factor to give her antibiotic. If she have fever and she's been ruptured more than
No, I'm still on your beta strep.
Yeah.
I'm still on your beta strep.
Yeah, okay, so then we'll go, if we don't have any sensitivity and she have an anaphylactic reaction to it, I will go to, I only say vancomycin to kill me, I know.
Well, it depends on where you're at. Some would tell you it depends where you practice.
Yeah.
Probably the choice for ACOG would be to use Cleocin 900. But again, vancomycin has been used by some, and it's one of the two that you choose. You're not going to choose ampicillin.
No.
And you're not going to choose a cephalosporin.
No.
So again, some would choose clindamycin, some would choose vancomycin, and that would be, but the ACOG is saying that we should use cliomycin. But again, it depends on your hospital. Some will have on their pharmacy bank, but mine does have Cleocin where I'm at. Okay. What kind of antibiotics do you give for a C-section? Do you give antibiotics for C-sections? You've got a C-section there on case number 1 and case number 4. Do you give antibiotics before you do a section?
Yes, I do. I give
what do you give?
I give ANSAP.
How much?
Depend on the size of the patient. If it's the patient more like less than 100 pounds, they'll go 1 gram. If she's more than 200 pounds, they'll go 2 grams.
I may say you were right when you made that case list up, but I would tell you you're wrong if you say that now. Because actually it's now 2 grams, and it's 3 grams if you have a lady who's heavy, like you mentioned.
Okay.
And that changed just 2 months ago. Okay? Just
Okay.
so that you know.
Thank
All
you.
right. Talk to me about the difference between gestational diabetes and pre-gestational diabetes.
Gestational diabetes is when you diagnose the diabetes during the pregnancy, and when pre-gestation, and if the patient have diabetes prior to being pregnant.
So which one has is there any birth defects associated with diabetes to the infants?
Yes.
Which one has it?
I would say the pre-gestational diabetes, but
Why does it have it?
because then she might have her sugar, maybe her diabetes is not controlled very well, so then can cause increased risk of birth defects.
So we should remember that birth defects always occur at the time of the growth of this infant, right? So most of the growth of the infant takes place prior to when we would diagnose gestational diabetes, which is at 20 weeks, correct?
Yes.
24, 20. Some people, we check it at 24, but if some of us will pick it up if we have a patient who has had a previous large baby, or she herself is a large person, we may check them before 24 weeks. But we check it at 24 to 28 weeks, correct? Okay, so what are those birth defects that a baby would have if she had pre-gestational diabetic, and you're going to tell me all the birth defects that baby could have because mom's not well controlled?
Birth defects. You know what? I don't know. Birth defects. Cardiac.
Yeah. Cardiac's one.
Another thing would be like respiratory.
Well, if they delivered early, yeah.
Then it can be so cardiovascular form can be anencephaly or spina bifida.
Yeah, those are probably more polygenetic. I'm thinking of one in particular, though, on the lower spine that occurs with an uncontrolled diabetic to her infant.
Okay, is that regression, caudal regression syndrome?
Uh-huh, and what happens to babies that you're looking at, do they have an increased risk of neural tube defects?
Yeah.
Yeah, they do. Some of them have renal too, but your biggest ones are caudal regression, neural tube, cardiac. Those are your biggest ones that you have with birth defects to a diabetic baby. Okay. Now, you have a patient, case number 7, that has gestational hypertension. When do you detect gestational hypertension?
Gestational hypertension is when we detect it after 20 weeks of pregnancy.
What if she comes in to see you at 20 weeks? You never saw her before.
Then, so we don't know if she had hypertension prior to pregnancy, you mean?
Mm-hmm.
Then still it's a it's gestational hypertension because we don't know anything about her before. Because it's not going to make a difference once she is hypertensive, it's the same management.
Well, what if I told you I like a better definition? If I was on the board and you're sitting in front of me, I would like you to say, gestational hypertension is a patient that if I see her before she reaches 20 weeks without blood pressure, I would call her hypertensive gestational if she occurs at 20 weeks. If she comes to me after 20 weeks, I would make the definition include that the blood pressure will resolve prior to 6 weeks postpartum.
Okay. So how do I say? Okay. So if it's
if somebody presents to you a case where the patient comes in at 22 weeks and you're seeing her for the first time, I agree, you and I would say that we would classify her at this point as gestational hypertension. However, my definition may change if she still has hypertension at past 6 weeks postpartum.
Okay, so after 6 weeks, then it will be.
Now, some will say 6 to 12, but true definition is 6 weeks. If they have it beyond 6 weeks, we probably will call it chronic hypertension and not gestational hypertension. When do you get worried about gestational hypertension? Let's say your patient in case number 7, this 36-year-old, which is a risk factor because of her age, but she has this gestational hypertension, and at 32 weeks she has a blood pressure, she's in your office and has a blood pressure of 138/79. You see her a week later and her blood pressure is 150/98. What are you going to do with her?
First of all, I do a complete physical and history and physical exam to assess if she's having headache, if she's having visual disturbance, if she's having right epigastric pain, to assess if she have any symptom of preeclampsia. So that's from the history and physical exam. Then I'll do blood. I'll do some urine testing and liver enzyme to check if she have protein in her urine, or if she have elevated of her liver enzyme, because to look for diagnosis of preeclampsia. So depend on that. If she's 32 weeks and she have the diagnosis with preeclampsia, then I would give her cortisone, because then because she's having an increased risk of delivering early. And I will start her on antihypertensive medication to control her blood pressure.
So, what is your workup? What does your workup include again? If you're putting her in the hospital, then
with the 150/8,
150/98.
32 weeks or 32 weeks. And she's preeclamptic? Yeah, then I do.
Well, I don't know. Is that preeclamptic? You tell me.
No, if her lab, okay, let's go with her labs first. If she have +1 protein, her liver enzyme is not elevated, then she's preeclampsia. We don't have mild anymore.
Well, let's go through. What's the definition of mild preeclampsia? Because I gave you 2 blood pressures, correct? I gave you one a week before, and then she comes back to you at 32 weeks, and I gave you 150/98. Her first blood pressure would not meet the standard. What's the standard to say that she has gestational hypertension, first of all? 140/90, right?
140/90, yeah. But if she has blood pressure more than 160/110, then that will be considered preeclampsia.
Okay, that's severe though.
Severe, yeah.
Yeah. You have to have 2 blood pressures that are 6 hours apart, or at least 2 blood pressures that meet the standard that are over, to call them preeclampsia. Now, where I'm at, we still use the proteinuria, and the maternal fetal I work with still does. But remember, they're starting to change that we don't use proteinuria as a finding, nor do we use other parameters that we used in the past. So just be up on your gestational hypertension and preeclampsia. I'm sure it will come up. In answering, just to tie it up so that those that asked the question, remember on the question I asked you about your Bishop score, remember, a way to remember that is DESCP. If you remember that DESCP, you got all the parameters on your Bishop score, but the 3 DES all have the possibility of 3. So that's 3, 6, 9, and your C and your P, that's 2. Those each get 2. So 3, 6, 9, 10, 11, 12, 13 is a total score you can get on a Bishop score.
Okay.
Okay? All right. Okay. Let's see.
We're going to go on to the next case, Laura. We're going to go to the case of the day now.
Okay.
Okay? Okay, thank you, Dr. Jolak.
So I'm still on the 14 or the 18?
Jolak. Yeah, you're on the 14th.
Okay.
Okay? Not a problem. Good. Awesome. Thank you for participating tonight. Okay, next candidate is Dr. Hong, and I'll go ahead and put up that case of the day for you. Hi, Dr. Hong, are you there?
Yes, I'm here.
Okay, wonderful, awesome. Let me pull up that case of the day. Get rid of that. Is that there? That's not it. Okay, here we go. Now, Laurel, you remember, just click once, and then the first question will come up, and then you click again, the answer will come up, right?
Okay.
Just click anywhere on the screen. Okay, click again. Okay, there. Don't click it. Don't click again.
Okay.
Okay, go ahead, Dr. Hong.
The maternal complications associated with multiple gestations, increased risk of preeclampsia, cardiopulmonary complications such as pulmonary embolisms, increased risk of DVT-PE, and gestational diabetes, increased risk of premature uterine ruptures if the patient has a prior C-section scar.
Anything else?
Yeah.
Oh, we'll go on and see if I can think of any more that they don't say. How's that? Okay. Remember, OB is one of those things I tell you guys to remember. Mom, placenta, infant.
Yep.
3 compartments. So again, I have a way of remembering this. Whenever I have anything OB, I always say on twins it's a ship. So A stands for abruption, anemia, acute fatty liver of pregnancy, amniotic fluid discrepancies. S stands for stillborns, SIDS, increased risk of surgery, i.e. cesarean sections, increased risk of gestational diabetes or sugar. H stands for hyperemesis gravidarum and hemorrhage, postpartum hemorrhages, IUFD, IUGR, and P is preterm labor, preterm delivery, postpartum depression. Those are just a few that aren't on there. There's a lot of them for twins.
Yeah.
A lot of them for twins.
The question is about maternal complications. Maternal. So.
Yeah, it is, but maternal complications of anemia, abruption, hyperemesis, all are considered 2 compartments, mother and infant.
I agree, yeah. So I could do an ultrasound, early ultrasound, and I would look for the lambda signs or the twin peak, the peak size, or the membrane thickness is more than 3 millimeter.
Okay. So
Do you want me to read? Do you want me to read the answer?
Sure.
So the, how do you determine chorionicity on ultrasound? So determined by genders of the fetuses, the number of the placentas, thickness of intertwin membrane, and whether the twin peak size versus the T size is present at the junction of the membranes with the placentas. Optimal timing for determining chorionicity is during the first and early second trimester.
So if you had, can you tell if you had 2, they determined by gender of fetuses, what if both fetuses were females? Would that help you at all?
No.
If you had a male and a female.
Yeah, if you have a male and a female, that's we can tell for sure that it is a dichronicity.
Okay. Yeah. So again, if you say something like determined by genders of the fetus, you would have to probably tell them when you're discussing it in detail, like we just asked you. Yeah.
Right.
Good.
Yep.
Okay. Let's see if I can get it. Okay.
How often do you perform ultrasound for fetal growth? I would do every 4 weeks, ideally.
Do you do a difference between dichorionic and monochorionic?
For monochorionic, I do every 2 weeks.
I agree with you. That's what I do. I don't know what this is going to say.
So ultrasound every 4 to 6 weeks for dichorionic twins and every 2 to 3 weeks for monochorionic twins.
If you had monochorionic, monoamniotic, what would you do? Would you follow them any different?
For because the growth scan won't show the difference if we do too often. So I would repeat every 2 weeks. However, I would start antenatal testing early from monochorionic, monoamniotic.
How early?
Approximately 28 weeks.
Yeah, some of us, if we know we got monochorionic, mono, let's just say it that way. Some of us would start it at 16 even. But that's correct. I'm with you. 2 weeks is what I do monochorionic, and 4 is what I do di.
How do you calculate growth discordance? It is the difference between the weight of the larger baby minus the weight of the smaller baby divided by the weight of the larger baby. So EFW of the larger twin minus the EFW of the smaller twin divided by EFW of the larger twin. If the difference greater than 20%, it is commonly defined as discordance.
How often, how reliable is your ultrasound to tell you the difference in weights?
It's quite reliable.
Do you know how much it's off?
It depends on gestational age. By third trimester, it might be 25% off.
Yeah, 20 to 25 at the last. I agree with you. Okay.
Do you recommend cervical length measurement and fetal fibronectin testing for prevention of preterm labor? In twins, I do not, because even though we find a short cervix on the twins, we don't. It doesn't change management because, yeah.
There's never been a study to this point that has proved them to be beneficial. That is correct.
Yeah. At what gestational age do you deliver twins? It depends on chorionicity or any complications. Usually, if a dichorionic, diamniotic twin gestations, I would try to deliver at 38 to 39 weeks, ideally 39 weeks. If it is monochorionic, diamniotic, I would deliver between 36 37 weeks, and if it's monochorionic, monoamniotic, I could deliver between 32 to 34 weeks after fetal lung maturity, after betamethasone for acceleration of fetal lung maturity.
Yeah. The practice bulletin on twins, for those listening, they do have a practice bulletin. It's called Twins, Triplets, and Higher Order Multi-Fetal Pregnancies, number 144, May of 2014, would say that the amniotic monochorionic twin gestations can be delivered between 34 weeks and 37 and 6/7 weeks. And the mono 32 to 34. And they are saying if these are reasonable women with uncomplicated twin gestations, they're stating that we can do it at that time. There doesn't have to be a complicating factor. And as you said, you deliver yours at 39, I think is reasonable. The bulletin does say 38 weeks.
Yes.
I don't know what she's got here. We'll see.
So with uncomplicated twin gestations, I deliver dichorionic twins at 38 weeks, monochorionic diamniotic twins at 34 to 37 weeks, and monoamniotic twins at 32 to 34 weeks.
And again, these are uncomplicated cases.
Yeah. How do you counsel the patients on the mode of delivery? The mode of the most important factor that determine the mode of delivery in twin gestation is the presentations. If it's cephalic presentations, I would counsel the patients vaginal delivery. If it is cephalic, the first twin is cephalic, I would counsel the patient either she can choose to deliver first twin vaginally, and then the second twins we can choose external versions or internal versions, or C-section for the second twin. If both twins presentations are other than cephalic presentation, I would recommend the patients go for C-section. So the answer is, if presenting twin is breech, the patient will need a C-section. If both twins are cephalic, I would offer a patient a trial of vaginal delivery. If the presenting twin is cephalic, but the second twin is non-cephalic, I would still offer the patient a trial of vaginal delivery, since I can do a breech extraction if necessary. Discuss the technique on how you could deliver a breech twin vaginally. So I would wait until the cervix are completely dilated and the presentations at ES of +3 to +4 depends on if it is a frank breech or footling breech. If it is footling breech, I can hold the fetal legs and gently apply gentle downward pressure until I see the scapula of the fetus, of the infant, and at that point I will rotate slightly, and I will use my index and my middle finger to go parallelly to the humerus, to the elbow of the baby's arm, and then sweep it across the chest of the baby to deliver the anterior arm. After that, I will rotate the infant in opposite directions to deliver in a similar factions of the posterior arm. And finally, I will have an assistant to apply suprapubic pressures to make sure that the head of the baby flexed completely, and I may apply my index and my middle finger on the infant maxilla bone to keep the head flexed, and apply gentle pressures to deliver the baby head.
What happens if it doesn't deliver? The head, you can't get the head to come out.
So I may use a pipette or pipette to help flex the head.
Let's see what she said, and then I'll ask you more questions. What's the best position? If you have to deliver a breech from below, what position would you like the baby to enter at the crowning? What would you like to prefer to see?
I like to see the frank breech.
Okay.
So the answer is wait until twin B has delivered to the level of the umbilicus. In a frank breech, I assist delivery of the legs by applying pressure on the medial aspect of the knee in order to flex the leg. After both legs deliver, grab the fetal trunk with a towel and continue to encourage the patient to push. When I see the scapular or axilla, I proceed to deliver the shoulder and arm. I pass my fingers parallel to the humerus to sweep the elbow and arm across the fetal chest and out of the vagina. I repeat the procedure, rotating the trunk so that the opposite arm is anterior. If the fetal head cannot be delivered with maternal pushing alone, I then apply pressure to the fetal maxilla to flex the head, Moriso-Smalley weight maneuver. My assistant applies suprapubic pressure to ensure flexion of the fetal head.
Now, the only thing that I would say in all of this is there's one way to determine if somebody delivers a breech from below or from above. What do you do when you're standing in your C-section room, and whether it's twins you're delivering and the second one is breech, or whether it's just a singleton and it's breech, what do you have your assistant standing across from you doing?
So my assistant will stand on the maternal side.
Well, who stands across from you when you're doing a section is somebody who's going to assist you, right?
Yeah.
What is she doing or what is he doing?
So basically, they will apply pressures on the suprapubic area.
What I want you guys to remember, when you deliver a breech, whether it's from above or below, whether it's twins or a singleton, I can tell if you do breeches and you know how to do them if you put your assistant's hand on mom's belly so the baby can't extend its head. Has to keep its head flexed. So you always want to tell them, and this doesn't say it either, but you must put your assistant not to push. I don't want any pushing. I just want you to keep the head flexed so that that baby cannot extend it. We do it whether we do a section. I hope everybody's doing that. When you do a section, the person standing across from you will lay their hand usually on the baby's head to keep the baby's head flexed. Okay?
Yep.
All right. Oh, that was a short one. So I get to ask some questions about twins then.
Yeah. Go for it, Laura.
Okay. Tell me the difference between monozygotic and dizygotic twins.
Monozygotic twins is the twins that come from one zygote, and dizygotic twins is the twins like different zygote, two zygotes.
So
you mean the?
So yeah, you want to tell me how many sperm, how many eggs?
Monozygote is one egg, one sperm. Dizygotic, it can is one egg. Dizygotic, two eggs and two eggs and two sperms.
Okay. Now tell me, you mentioned to me that which one of these is higher risk for both the infant and we said something about we deliver one of them earlier than we do the other. Which one of these has the highest risk to the infants?
Monozygotic is a higher risk than dizygotic, and monoamniotic is a higher risk than diamniotic. But basically, they are high risk.
Why is that?
Because the baby may, like the twins may have a complication called cord entanglements and may die suddenly. For monozygotic diamniotic, the twins may have a condition called twin-twin transfusion syndrome.
What's that involve?
So it's a complications that in which one twins will basically suck on the blood from the other twins. It's used to be the cause is usually because of the abnormal blood vessels, the in the placenta, the shunt in the placenta, and one twin will become donor, and the other twin is So the donor twin may develop severe anemia and high cardiac output, heart failure, and may die.
So you want to tell me, what do you look for when you look for a twin-twin transfusion on the ultrasound? Is you want to have them monochorionic and diamniotic twins, right?
Yeah. Mm-hmm.
And the one twin that you told me is a donor twin, what else do you see on the donor twin? Tell me the donor twin. That's the twin that gives to the other twin. What exactly am I going to see on that twin?
So the donor twin. So first of all, growth discordancies, and then the donor twin is bigger and may have ascites, may have pericardial perfusions.
That's a receiving twin, right? Receiving twin you're giving me now. What does a donor twin look like? The donor is the one that gives to the other one.
Sorry, the donor twins will be smaller and we may not see the bladder.
So we can say, that's okay. So what does the fluid look like?
So the donor twins may have an oligohydramnios.
There you go.
Yeah.
So this small twin is small. It has no fluid. It may have no bladder. You see, we sometimes call it a stuck twin. Okay, a stuck twin.
Yeah.
And the receiving twin then is this baby that looks like what again now? And what's the fluid look like?
The receiving twins may have like polyhydramnios, may have pericardial perfusion, effusions, may have an ascites, may look bigger, and have a big bladder.
Yeah, I tell everybody to always think of hydropic. The receiving twin always is hydropic, and so these twins. So to make a long story short, when we have a twin-to-twin transfusion, we have to have discordant growth. We have to have amniotic fluid discrepancies. We have to have monochorionic. We have to have the same sex. Okay?
Yep.
So again, you got to use all your definitions. And how do you stage a twin-to-twin transfusion syndrome?
We use a quintile system, quintile score. To be honest, I don't remember detail. I have to look up. But there are 4 stages of four stages.
There's actually 5 stages.
5.
Yeah. One is monochorionic diamniotic gestation with oligohydramnios and polyhydramnios. And that's a mean, less than 2 centimeters or greater than 8 centimeters on the fluid. Stage 2 is absent or empty bladder in the donor, like you mentioned. Stage 3 is abnormal Doppler ultrasonography findings, okay? And stage 4 is hydrops. Stage 5 is death of one or both twins. Now what happens if you have the second twin? You're doing just fine. You got these twins all the way to 35 weeks. And no, let's make it 30 weeks. And one twin dies. Going to deliver the other twin? Let's say it's the second twin that dies.
I would not. I would continue with the pregnancy with increased antenatal surveillance, and I would give I would give a course of betamethasone to accelerate fetal lung maturity, and I would deliver when there is any obstetrical indication.
What would those indications be?
Such as BPP 4/10, or NSD BPP non-reassuring fetal status, or IUGR with abnormal Doppler flow, such as absence or reverse endocytic flow.
What if you had monochorionic diamniotic twins and one dies? Let's say the second one dies. You going to change anything?
I could not. However, I could have an consultations with high risk OB doctor, and I would find out what is the reason. I would try to see whether there is any abnormal blood vessels, the placenta abnormal blood vessels, and the patient may benefit from laser surgery to seal the communication.
Okay. The biggest thing you want to say here is you have to be honest with the mother. When one twin dies, the other one's jeopardized. And when you have monochorionic twins, there's a higher risk for that baby that's left. But you're right, if they're not mature, we're not going to benefit them to deliver them. And unless you deliver them rapidly, a monochorionic, the baby usually has neurologic problems and medical problems, and you got to be very upfront with the patient and tell her these. Those are the biggest things that happen, but we don't usually deliver the twin that's still alive because there's not been any proof that we have a better outcome for a premature baby outside mom. But you have to be honest and tell them that the baby will have some major medical problems. Okay?
Yep.
Okay. All right.
You can stop, Laurel, you were good here, so you can stop at 10
Okay.
o'clock.
Okay.
Okay, great, excellent. And Dr.
Thank you so
Hung,
much.
you did a great job. Thank you
You're
very
welcome.
much.
Thank you.
No problem. And I want to thank everybody that was here tonight. And just a reminder, there's camps are filling up, and there is some camp space available in Orlando next weekend. So please look at the website. And if you have any questions, feel free to send me an email or a text message. Okay, this is Dr. McSherry concluding tonight's webinar. Faculty was Dr. Laurel Walton. First candidate was Dr. Abe Jolak with case list review, and second candidate, case of the day, was Dr. Hung. We'll see you all tomorrow night for Dr. Polani and Dr. Mira. With the case of the day tomorrow is going to be a surprise. Take care, guys. Have a good night, and we'll see you all tomorrow. Good night now. Thank you.